Okay. This is Dr. Nitin Ankle and a professor in JL Medical College, Belgaum. I'm going to give a talk today on tracheostomy. I hope my voice is clear and sound for you people. And this is basically a very huge and vast topic that we are going to deal with. And I'm trying to minimize it as much as possible in the sense that not to go and put unnecessary details. But I will advise you one thing that you consider on the headlines which are there. As we know, like before we start on tracheostomy, it is wrong if we do not give or do what I can say reverence or importance to the people who have or who are the ancestors to us. Now, how this tracheostomy is important? Now, way back more than 200 years back in 1799, Dr. Elisha Dick, a former pupil of Benjamin Rush, was called to help the then president of USA, George Washington, and she used to treat various conditions by either using the aqueous bleeding. In those days that was very common, and various other medical procedures. She suggested that Dr. Dick suggested that tracheostomy should be performed in this to to General Washington, and the panel was set up and they decided that to go against it and not to do any of the procedures or intervention in them. And ultimately what happened was all the history noted that he had died because of obstruction of the upper airway. So this tracheostomy is very important procedure and it has to be done in the right way at the right time to save a patient's life. Now this tracheostomy is one of the oldest procedure and right from the ancient Greek or even Indian times it has been shown and been described by various people. But the real in the modern noted history, it was Chevalier Jackson who is in 20th century brought forward all the principles of tracheostomy which have been put forth by him. And if we go through the history, throughout the history of mankind, it has gone through various changes. What the books have described in our texts have been there been a period of legend, which was before 2000, BC to up to 1546 AD. Then that period of legend means that is a period wherein it was legendary to perform this particular operation. Then came the period of fear because a lot of competitions were known, and this lasted from 1546 to around 1833. This was in this period only a brave few would perform this procedure, but with a very grave risk of their whole reputation and life also. Then started the period of dramatization from 1830 to 1932, wherein tracheostomy was an operation of life or death. People knew the importance of it and the airway also. And as you know, in the emergency care, ABC, A stands for the airway, and that is where the tracheostomy is. So it is the number one category where the operation and procedure everybody should be well versed with. As far as ENT subject is concerned, all of us we should know about this, including that how to do it and what are the emergency care to be taken. And in those days, it was only used in emergencies, only in acutely obstructive airways. Then came the period of enthusiasm from 1930 to 1965. That was when it was rather period wherein it was overdone. When you think of your tracheostomy, you do it. That was the dictum which was followed. And from 1965 onwards to now, what has been is the period of rationalization, which is much more in a much better way it has been put forward. And we have the other options of intubation also. So the many times you may have to, rather it's better to avoid tracheostomy because it has got all its own complications also. But if need be, when time is there, then we have to rationalize the thing and go ahead with the tracheostomy. So again, giving the reference to this person, that is Chevalier Jackson, who has standardized this technique. What are the important things that he's done? He has given emphasis the incision of a long incision because exposure should be very good. He has also wrote about the importance of avoiding the injury or handling of the cricoid cartilage, because if you handle the cricoid cartilage, it will lead to stenosis. Then the thyroidismus, which comes in the way, has to be properly dealt with. We'll come to it step by step when we are describing the procedure as such. Then the slow and careful surgery, use of proper cannula, and meticulous post-operative care. All of the things have been very well documented by Chevalier Jackson. Now we'll start with the anatomy, because any surgery you have to start, we have to have the basic anatomy, because without anatomy, it is very difficult to understand or perform any surgeries. Now, as we know, trachea is a midline structure, but still all said and done, there are few layers of soft tissue that come in a way between the skin and the trachea, and they are basically consist of the skin and superficial fascia. The superficial will also have the platysma in that and the subcutaneous tissue. Then comes the deep fascia, which is the again divided into three parts, that is the pretracheal, then prevertebral, and the membranous part. So the pretracheal fascia, up to this level we should know about the dissection, I mean the layers, the layout, and if we put the patient in a proper position, we will not come across any important structure in midline as long as you stay in the midline. Only few muscles will come and they are not a bit of concern, because if you, as long as you're not going to injure the muscle fibers, will not come across much of the bleeding. So meticulously you have to see the muscles which are there. The muscles which you come across is the sternothyroid, sternohyoid, thyroid, and omohyoid. Now dissect it in the midline and we'll reach the trachea. Of course, many times we may have abnormal thyroid glands which might be coming in the way, and in that cases usually they come in the layer of second and fourth tracheal ring, and in that case we may have to divide it and achieve hemostasis and go ahead with it. Now this is a picture which will make you understand the anatomy in a proper way. As you can see, this is the hyoid bone, and if you palpate on the neck, you'll be able to feel the hyoid bone, and the most prominent part in males is the what you can say that tracheal this thyroid cartilage. Then comes the cricothyroid membrane, and this is the cricoid bone which you have to feel but not to injure. And from here the trachea starts, which is usually 16 to 22 rings, and the counting starts from here. Usually we try to avoid the first and second ring. The ideal tracheostomy should be between second and fourth ring. So always when you do tracheostomy, that all these anatomy which I have been highlighting has been kept in mind, and it is best to be done into the second and I'll bring a picture there. Yeah. It is best to be done in the beyond the second, that is between the second and fourth tracheal cartilage. You have to avoid going anywhere near the cricoid, and if at all the isthmus comes in between, then it can be easily retracted upwards. And sometimes it may not be able to possible to retract it, or it comes in the way, then nicely ligate it and take it away from the field. Now there are two other procedures apart from tracheostomy which have come into foresight or the practice in the recent or previous few decades. That is the percutaneous tracheostomy, which is usually done to the first and second, but again remember, away from the cricoid. And there's a cricothyrotomy, which is an emergency procedure when you don't have any instrument and you are maybe not in the hospital also that time. This is the cricothyroid membrane, wherein a simple even a small metal tube is enough to just puncture it so that the airway is established and patient's life is saved. But of course, this is a temporary procedure. Afterwards, the patient will have to undergo a proper tracheostomy and tracheostomy care, and this may have to properly close afterwards. So this is the place wherein they do the cricothyrotomy, and this is the between the cricoid cartilage and the first and second. In this area, you should do the percutaneous tracheostomy. Okay. Now, before we go into the steps of tracheostomy, the differentiation between the word of tracheotomy and tracheostomy. Tracheotomy is the surgical opening of the trachea, whereas tracheostomy is the creation of a stoma at the skin surface, which is going to lead into the trachea. And there are different types of tracheostomy. First is either it can be temporary or permanent. Permanent, we already know patient is going to live a long time care of tracheostomy, or he may not be able to breathe from his nose again at all, maybe because of CA larynx, or wherein you may have to resect the larynx, or any other surgeries, or he might be comatose, or there are many other reasons. We'll come to the indications later on, but it might be temporary or permanent. Broadly speaking, the tracheostomy can be permanent or temporary. Permanent usually already we know the cause, and that's why it is an elective procedure. So there is no, surprises in that. We have to properly plan and do it. But temporary tracheostomy, sometimes it may present directly in the casualty or emergency OPD, wherein we may have to do emergency tracheostomy. So I am going to talk a few lines about this emergency tracheostomy also afterwards. But all said and done, the steps remain the same. Now, apart from that, by the procedure as such, there are three different ways in which the tracheostomy can be performed. One is a open surgical tracheostomy, which is the best and safest and is a properly planned thing. Then is a mini tracheostomy, which can also be a planned one, and is a percutaneous tracheostomy when the patient is usually in the ICU and will not be able to, maybe shift to the OT and some other stents are there. That time we may go ahead with the percutaneous tracheostomy. This has gained importance nowadays because it has got least bleeding, but it needs a bit of expertise. What do we achieve by doing tracheostomy? One is it will bypass the larynx. Remember, when we bypass the larynx, the patient is going to lose his voice. So always important that the patient will be left with some form of communication or emergency bell by the side of the bed. So whenever he needs something or if there is any emergency, he should be able to call a sister or anybody nearby, so that he can convey it by any other means apart from vocalization. Then second thing what we achieve is reduction in the respiratory dead space. Now whatever the space above the larynx or above the level of trachea up to the nose, that much area is of the area which is filled with the air is not used for gaseous exchange. The air which is there in the lungs only, that much is used for alveolar exchange, and that area is dead space is reduced with this. Second, third one which is there is the function of the nose, and the upper part of the larynx is totally lost. So the mucosa and the the nasal issue, the hairs are there. All of these are important for removing the particulate matter and humidification of the air, so that the humidified, properly filtered air enters and reaches the lungs is lost, and this has to be taken care by artificially doing it. Second, one more important thing is the infections. The chances are increased because the upper part of the airway has been removed from the picture, and hence that whatever protection is it is giving us is removed, and there is definitely increase in the risk of infections. And all said and done, we end up with a tracheostomy which is going to be there permanently in the trachea, and the tracheostomy can be of various materials. All of them, all said and done, are always a foreign body, and they're going to cause a bit of local inflammation that we have to take into consideration. That irritation and local inflammation may lead to increased secretions initially till the patient gets used to it, but later on it is not much of a problem. Now this is basically, in all the books. I will not concentrate more on this, but as a part of a topic, I'll have to go through the indications and mention it to you. Basically, the three main indications are either the upper airway obstruction, the mechanical respiratory insufficiency, and respiratory difficulties due to secretions. These are the main three basic groups wherein we may have to go ahead with tracheostomy. So coming to upper airway obstruction, nowadays it can be managed by endotracheal intubation, so it is a less common indication nowadays. But mechanical respiratory insufficiency, whereas which is commonly seen in say drug intoxication or head and chest injuries, elective surgeries, neurological disorders, wherein the patient is paralyzed, then chronic obstructive airway disease, then patient who is going to need a intermittent positive pressure ventilation, all of them will are the indications for tracheostomy. Now coming to continuing the indications, the respiratory difficulties due to secretions. There are conditions wherein the secretions are more. That is, whereas then there is a pneumonitis or other infections, or there is a congestive heart failure, or pulmonary edema, chronic lung disease, bulbar disease secondary to cardiovascular ischemia or stroke. All these will have a lot of secretions, and they will come in way of normal respiration and will not allow the gaseous exchange to go on, and mechanically prevent the patient from having a proper SpO2 levels. In these cases, again, tracheostomy is an indication. And the other indications are if the patient airway, when the upper airway is potentially at risk, major operation. Whenever the patient is undergoing any major operation, say surgery, any head or neck surgery, or surgery in the oral cavity, we know that in the post-operative period, the patient is going to have a lot of edema and swelling in that area, and he has at a risk of compromising the airway. So in such patients, it is preferable to do a elective proper tracheostomy first, so that the patient will not have any problems in the post-operative period as far as SpO2 is concerned. Apart from that, a lot of patients have trismus due to any other reasons, and in that case, the mouth opening is not much, so the patient may not be able to have endotracheal intubation through the oral cavity normally, which the anesthetist does. And in these cases, again, it is better to do tracheostomy first, then have the intubation. Have the tracheostomy inside, and then connect the anesthetic tubes to that, and go ahead with the operation. So these are the various areas wherein we have to do elective tracheostomy. So there are hardly any contraindications because it is a life-saving procedure, but few are there and which we should know, and that is the active infection at tracheostomy site. We know that the site of tracheostomy, and if that area is totally infected, then it is a difficult, or we may not be able to do tracheostomy as such. We may have to go for any alternative way wherein the airway can be established. Then burn at a tracheostomy site, then poor pulmonary function. If the pulmonary function itself is poor, then there is no way that a tracheostomy is going to help, because tracheostomy is going to only bypass the upper airway and going to provide the air to lower down. But lower down, the lungs also has to function properly, if that the SpO2 has to be maintained and the proper oxygenation of the body has to occur. And sometimes this is last, for the sake of mentioning, I mentioned this last is inability to transport the patient to operating room, when there is, say, sometimes there is acute respiratory distress syndrome, when the time is not sufficient to shift him. That in that case, we may have to go ahead with cricothyrotomy or some other procedure. So in the meantime, when the other things are being arranged, the patient oxygen or SpO2 is being maintained by doing cricothyrotomy and giving 100% oxygen, and then shifting him to the OT. I hope my speed is okay. If I'm too fast or something, then kindly message me so that I can accordingly change so that you'll be able to follow me properly. Now, as for any other surgery, we have to do a pre-operative planning. That is a complete blood count. Preferable to have hemoglobin more than 10%. Then we have to do studies like bleeding time, clotting time, in the sense of PT, APTT, INR, all the bleeding coagulation profile. And if aspirin or any antiplatelet drugs are started, that is better to stop it if you are talking about electrotracheostomy. But if it is emergency, then we have to go ahead no matter what it is. And of course, important nowadays with medical legal issues are consent for tracheostomy. This has to be properly taken. Without that, we will end up in the law of, end up with a lawsuit against you in a court. And consent is one of the important things which we cannot miss upon. I'll just briefly tell you the various steps wherein we go ahead with the open tracheostomy, open surgical tracheostomy. First, we have to do adequate preparation. The technique has to be good, and excellent post-operative care has to be there. A best area wherein you can do the tracheostomy is the operation theatre, because all the things are available there, including oxygen and in the instruments, and including the Boyle's apparatus and other anesthetic equipment, so that immediately the patient can be revived. But sometimes we may have to do it in the ICU also, when the patient is not able to position there, or it is not possible to be taken to OT, then it is possible to do bedside tracheostomy also. Now, first is the position. As you can see here, the position is simple supine position with the sandbag between the shoulder blades, and neck is extended. This extension of the neck brings the trachea in the midline and prominently and anteriorly. This position is very important. Without this position, we should not go in for tracheostomy, because we will unnecessarily come across various structures in the neck which come in anteriorly and will be in the way of your surgery and cause unnecessary bleeding. So this position helps the trachea to push anteriorly and come below the skin, and hence away from all the important structures, all the important structures which are there in the neck, all the vessels, all the nerves, all of them go laterally. So be in the midline, and that is the key in doing this particular surgery. Now, once the patient is, put in the position, as for any other surgery, you have to drape the patient. Before draping, you have to paint and see that all the surgical field is cleaned and shaved, and it is cleaned with povidone, iodine, spirit, and all the usual techniques that we do. And I will not go into details because that becomes too basic. All of you know about that. Then comes to incision. Now there are two types of incision. One is either vertical incision or horizontal incision. Here you can see the vertical incision and horizontal. Vertical incision is cosmetically not so much acceptable, but in emergency situation it is very fast and hence can be done in emergency tracheostomy. But in elective, we prefer a horizontal incision. And once you take the horizontal incision, of course, the approach is going to be the same, the vertical itself. So once you take the horizontal incision long enough, this incision is preferably taken, say, below the lower level of the cricoid, palpate the cricoid cartilage. The thyroid cartilage below that is a ring of, which is a complete ring of the trachea, which is below the larynx, so that is the cricoid cartilage. And say around 2 finger spread below it, or say 2 to 3 finger breadths above the suprasternal notch is the area wherein we do a horizontal incision. It should be long enough, at least say around say 3 to 5 centimeters in length, depending on the structure of the neck. People with long neck will be, it is easier to do tracheostomy. People with short neck and say with a fat neck, it's difficult to do tracheostomy. Now, once this one incision is done, we retract the tissues, see that trachea is in the midline. You palpate it, always you can palpate with your gloved fingers, the tracheal rings there, and always be in the midline. If you come across the anterior jugular vein, which is shown over here, it can be detected, but sometimes it is not possible. Then you just ligate it and cut it off and take it away from the field. Now, once that is done, then go in the center, display, then give the incision over the fascia and expose the trachea properly. Then many times we come across the thyroid isthmus, which is there on the anterior wall of trachea. This can be retracted majority times, but if it is not possible, then you clamp it with right angle clamps, transect it, ligate it, and take it away from the midline. Now comes the important step. Before you go in for the incision on the trachea, we have to infiltrate this area again with 1 in 2 lakh adrenaline and see that the part is totally anesthetized. of course, if it is we are doing it under local anesthesia, but many times we do it under general anesthesia, then this step becomes not unnecessary. But also then this is an important step because we do not want the cough reflex to suddenly make the things difficult and make the trachea lose its position, and you also get lost in the surgical field. So the patient has to stable at this moment, and with the required hook, we have to stabilize the trachea, incise the pretracheal fascia, and then expose the cartilage. Once the cartilage is exposed, some people recommend that if it is possible, better to remove the one or two tracheal rings, completely excise it. In particular, as in younger children, we may have to. It's very, pliable, and just a single incision will be able to retract the rings also, because they are not properly ossified, or even cartilage also not properly formed. So a simple incision will be making it possible to just make an opening in the trachea. After that comes the important step wherein we have to put a stay suture so that you don't lose that field again, because already I opened the trachea. And during this, one thing I want to say, before you make the opening in the trachea, we tell the, if the patient is under GA, we tell the patient to slightly, we tell the anesthetist to slightly pull the intubation tube upward so that this area becomes away from the digestive tube, and so that you can make out the hole here. And once that hole is made, we have to suture it with the skin. So these are traction sutures which will which is applied to the trachea proper, to the stoma properly, or the wound edges, and a proper tracheostomy tube is performed. Opening is performed. Once it is performed, then this tube, which is the what I have shown here in a photograph, is a vortex tracheostomy tube, which is a cuff tube. We have to check that cuff is working, and then only kept by the side of the patient before all this procedure. This is usually done by a sister or one of your assistant. And the moment the trachea is open, we put it inside. And this, once it is put inside, the flanges are put again sutured off the skin, so that the tube will not move again, at least for the next 7 days. And this part is again attached to the oxygen supply, or the oxygen or the anesthesia is given to in the custody of the anesthetist, so that whatever gases things are being given has to be given through this opening. The size usually what we use is 7.5 to 8 in females, and 8.5 to 9 in males, and that depends from person to person, and an experience will be able to make out the size. But in general, in India, as far as concerned, the size is 7.5 to 8 millimeter in females and 8.5 to 9 in males. As I told you, it's written there here. Now, when you're doing under local anesthesia, remember that we have to properly pre-oxygenate the patient, because more than 3 to 4 minutes of deprivation of oxygen to brain, the patient will have severe neurological deficits. So the pre-oxygenation is very important. And once the tracheostomy tube is inside, proper suction has to be done, and whatever blood and secretions which are there because of the irritation inside, and the cough and pneumonitis, whatever is there, all of them are sucked out with through the tracheostomy tube, and then ventilation is started through the tracheostomy tube as such. Now here is a placement wherein it is properly sutured to the skin, and you can see the tracheostomy tube is there, and with proper adhesive tape you can reinforce this tube there properly. Now here we remember that the wound is again closed off, but it should not be closed off too tightly, otherwise we may end up with surgical emphysema. Now some points regarding emergency tracheostomy. I told you I want to talk about this. Now in this case, you remember that in 4 to 5 minutes anoxia is going to cause death, and creation should be very fast within 2 to 3 minutes. So you should be very sure, fast and precise. The position and the sandbag under the shoulder blades is all the same, but we have to explain the procedure to the patient, and many times the patient is awake, so you should maybe have have to go on talking with him so that he is relaxed, and the procedure can be performed in a painless way, so that his obstruction is relieved. This already I told you, we have to instill a local anesthetic before doing a trachea or opening a trachea, so that we suppress the cough. Otherwise, all the field will move and the tube made the cough out. In this emergency tracheostomy, one more point important is that we may not be able to use the tracheal hook or cricoid hook to stabilize the trachea, and we may have to use the dominant hand, the index and the middle finger, or the index finger and thumb, to stabilize the trachea with the cricoid cartilage, and then make the opening, and immediately we retract and put the tube inside as early as possible. As I told you, we avoid incising the cricoid cartilage because that is going to cause injury to cricoid cartilage, and injury to cricoid cartilage definitely 100% take you to a situation wherein we have tracheal stenosis. Once all the procedure done, then the cuff of the tracheostomy is there, which I showed in the initial part, has to be inflated so that there is an unnecessary aspiration of blood and other things can be prevented, and at the same time, the leakage of air is also stopped. Now, once the tracheostomy is formed, there comes the immediate post-operative care. Immediate post-operative care, we need a surgeon, a nurse, patient, and a family, and it's best provided in the intensive care unit. Constant humidification and of the air and filtration of the air is required. Regular suctioning initially 1 or 2 days, the suctioning may have to be frequently as and when the need be, whenever the blockage is there or whenever the noise breathing occurs, the suctioning has to be done. But later on, as the days, hours go by and days go by, the secretion will come down and the amount of suctioning required will be less and less. But in the initial days, we may have to do the dressing and suctioning frequently because this tends to become very wet and the discharge tends to accumulate on the wall spaces. The first tube change usually is done after 7 days, but it is safe to perform after say 3 to 4 days because by the time the tract is formed and it is unlikely that you will miss the opening again. But anything happens before that, it becomes a hell of a job or rather a very difficult situation wherein we may have to again search for the opening of trachea. And best is to have the tracheal dilator by the side of the table, by the side of the patient along with the extra tracheostomy tube so that if at all something happens to the first tube, then it can be replaced there. Now this humidification, as you can see in this picture, is can be done through a simple device wherein this is a syringe, and on that we have the gauze piece which is always kept wet. So whatever air goes inside is always humidified. This humidifier is going to keep the trachea moist and maintain some secretions of the or the transport of the secretions, and also is going to prevent the crusting inside. Because crusts are going to be bad for us because they are going to cause mechanical obstruction there. Always and always wear the gloves. Always have the wash and have sterile disposable suction tubes by the side, and never allow to have the area to be undergo infection or any other thing, because hospital acquired infection with nowadays having the resistance to majority of antibiotics which have been used, we better to be prevented than to take care of it later on. Now, what are the emergency situations that you can come across in the post-operative period? First is the obstruction. Now, this obstruction can be for a very short time, and the patient will have very issues. Always the SpO2, the monitors are there which will tell you the oxygen saturation. And if it is falling, then immediately look for any blood clots or any plugs which are there, or if is there any displacement of the tube, and that has to be immediately corrected. Later on in the later period, say after 2 or 3 days, the granulation tissue might develop, and this may also cause obstruction. In that case, we may have to excise the granulation tissue. And in the meantime, you can put a smaller size tracheostomy tube inside with connected to 100% oxygen and let the oxygenation of or SpO2 of the patient be maintained throughout. The second emergency situation is there is acute total obstruction. Here, if the tube is displaced or the cuff is displaced, then relieve the cuff. Have the suctioning done properly. If there is any mucus plug, you remove it. Rarely we may have to reinsert tracheostomy tube, but usually if the humidified air is provided and frequent suctioning is done, this situation will not arise. Other emergency situation is the accidental decondylation. This might occur when there is a patient is undergoing chest physiotherapy, or when the patient has got severe bout of coughing, or during suctioning. Sometimes a patient is psychologically unstable. He may have the tracheostomy tube pulled out, and this can be simply avoided by suturing the tube to the skin so that it becomes impossible to remove the tube. And as I told you, we have to keep the tracheal dilator, that is Trossus tracheal dilator, to be kept on the bedside along with the extra tracheostomy tube there. Other rare emergency is the hemorrhage. This is whenever you are not done a good job properly, or when there is an anterior jugular vein starts bleeding. Then in this situation, major times mild bleeds can be stopped by giving a local pressure. But if it is a continuous ooze or severe bleeding is there, you may have to shift the patient into the OT again and re-explore the area. And if at all bleeders are there, they have to be ligated or cauterized accordingly, and hemorrhage should be taken care of. A few words regarding pediatric tracheostomy. In children, as you know, a very small working space is there, hardly around 2.5 centimeters in neonates, so at maximum to 6 centimeters in a 10-year-old child. The Cricoid cartilage, you should remember, is the more important landmark than the thyroid cartilage, because thyroid cartilage is not properly developed in children, and you have to go in for palpating of the cricoid cartilage and go below it and then make opening there. So the most easiest landmark in or prominent landmark in children is cricoid, and that has to be identified. So here this is the other important thing that we have to take into consideration when you are doing pediatric tracheostomy is the structures in the mediastinum. When you extend the neck, the majority of the structures in the chest are going to be pulled up, and the apex of the lung also might be, or the dome of the lung might also come in the neck, and this should be taken care of. You should avoid it totally. Otherwise, if you incise it, there will be collapse of the lungs, and you will be landing up in a very serious problem, you and the patient also. And in children particularly, we have to see that the tape switches are put for the tracheostomy tube. Now that is regarding pediatric tracheostomy. Then coming to equipments, there are various types of tubes. I'll just deal in brief with it, because depending on the situation, we may have to have various types of tubes which are available. Now, this is a typical vortex tracheostomy tube, which is you can see on the picture on the screen there, and it has got various parts. This is the obturator, which is used when the tracheostomy tube is being put inside for the first time. Then it has got an inner and outer cannula. Over here, the outer, you can see the opening there. This is useful whenever the patient has to vocalize. This can be put on later on after the patient is stable and patient wants to speak. That time, this can be this type of tubes can be used. This is the area wherein we have to put the syringe, push the air inside, so there is chest cuff blows up and opens up and gives adequate pressure over the lateral parts of the tracheostomy tube. So the space between the tracheostomy tube and the trachea are neutralized, and there is no leak of air. This is very important when the patient is under positive pressure ventilation, or when chances of aspirations are there. So these are the various parts of the tracheostomy tube. For long-term care, we have to go at the metallic tubes, which are there in chronically, the tracheostomized patient, and there are basically of two types. One is the Jackson's type, and other is the Fuller's type. Apart from that, we have other parts like the Cornings and Durhams, but they are of various types, and they can be used in various other conditions. But commonly used ones are the Jackson's type, Chevrolet Jackson type, and the Fuller's type. Fuller's tube is used whenever the patient is wants to vocalize, and it's possible to have a proper larynx above the trachea, or the condition is such that the patient is it's possible for the patient to vocalize. Then this tube will be helpful for the patient. Where the tubes are made of elastic, they are the least irritating, and they will not cause much of the mucus secretions. They are less traumatic. And these cuff tubes are of advantage because whenever we need a positive pressure ventilation, this can be given, and they will provide, prevent any leak there. But one thing we should take care whenever the cuff tube is used is that it should not be kept inflated for more than 1 hour. Every 1 hour, we have to deflate it and relax it for at least 5 minutes, so that the circulation is maintained in that area of the trachea, so that this pressure is not going to cause any pressure necrosis there. Otherwise, we may end up with other problems of trachea and tracheostomy, that is like fistula or tracheostomy fistula and other parts. Now, this inner tube and outer tube, the concept of this inner tube and outer tube. See that what we are seeing here is a tracheostomy tube, which has got an outer tube and the inner tube. The inner tube is slightly longer than the outer tube, and this for a simple reason that whenever the inner tube is blocked, then you can just remove the tube, and the patient goes on breathing through the outer tube. And in the meantime, we can clean the inner tube and reposition back into the tracheostomy tube as such. This fenestration I already told you, this is simple. It can come with a single hole or multiple holes. Commonly used is single hole, and this will allow the upper area also to be used. And this can be done as a step before decannulation, or whenever the patient can vocalize also, or the structures above the layer of trachea are normal. Then that is what I mean is larynx and other structures are normal. That time it can be used so that the patient can vocalize and communicate with the other people normally. There are flexible tubes wherein you come in a situation wherein the trachea is not in the midline, or it is already stenosed and it is has got a curvilinear path. Then we have the flexible tubes which can be adjusted and put inside, so the airway is maintained. Now this is a Montgomery T tube. Again, this is used in the patients of tracheal or laryngeal stenosis, which has got long T-shaped thing, and this can be inserted inside. This is made of elastic, and this will kept for a long time, say around 4 to 6 months many times, and till the stenosis is treated properly either with lasers and other things, and then a normal trachea is re-established. That time we may have to use this for long term Montgomery tracheal T tubes. And once you come across a patient who is going to need a tracheostomy for life or for a long term, then there comes a situation where, because the patient is not going to stay forever in the hospital, the tracheostomy self-care has to be there. And this has to be done in a proper fashion. A system has been developed in Nottingham to teach the self-care, and it is in a stepwise fashion. To tell you broadly, the main things that are important in tracheostomy self-care is basically it needs 10 elements. One is the patient will be able to recognize the need to clean and change the tracheostomy tube. The frequent changing cleaning is required. Then you're removing the inner tube, which should be able to do. Cleaning by himself, he should be able to do. And reinserting the inner tube by looking in the mirror. These are the things which are going to do. Preparation of the equipment to change the outer tube and applying the tapes, all this by looking at the mirror too. And the remaining 4 points are the removing the outer tube, cleaning the outer tube, inserting the outer tube, and skin care. All these things should be taught to the patient properly before discharge, so that the patient is in a position to take the care properly. Now this actually is describing various steps. First is acting. The medical attendant will perform the task and tell the patient. The attender also is by the side, and we have to go on actively teaching him. Then comes the teaching part, then the guiding part, that is the patient is going to do, and the medical person is going to be by the side and just guide him through the procedure in a proper way. Then comes the supporting, that is the patient is going to do with not much of guidance, but by himself or herself. And last is the self-care. The patient is, you're confident that the patient can take care, and then you can think of considering the patient to be discharged. The 4 basic skills we learned as the suctioning, the tracheostomy tube change, care of the stoma and surrounding skills, and if need be, emergency skills. If these 4 things are known by the patient, then you can be happy to discharge him, and the patient also can be safe and sound. Now coming to the last part, there is the immediate and intermediate and long-term complication of tracheostomy. This I'll do briefly because we may run short of time. So main complications of tracheostomy are the immediate complications. They are mainly the anesthetic complication, the hemorrhage, air embolism. I already told you how to deal with these things. So this hemorrhage, we have to go cauterize or ligate the bleeding. Air embolism, we have to prevent it by a proper care. Apnea, many times the patient is having a obstruction for a long time, so the whole system and even the respiratory system in the brain has got accustomed to PCO2 higher levels. And once the normal oxygen is the oxygenation of blood is realized by doing tracheostomy, the patient will go into apnea and cardiac arrest also. So simple thing is just give him 100 SpO2, sorry, carbon dioxide through the tube, and the patient respiratory center will be stimulated, and again the respiration will start. Sometimes you may not have the access to carbon dioxide, then just close off the opening of the tracheostomy tube, wait for say a minute or two. The oxygen, carbon dioxide will develop inside by itself, and once the SpO2 rises, again the respiratory center is stimulated and the patient will start breathing. Air embolism is a serious complication, and this can lead to crisis with death also. This can be avoided by surgical technique and meticulous hemostasis. Hemorrhage, I already dealt with it, so I'll not go into that. Apnea and cardiac arrest also, I just now mentioned how it is to be managed. And then the local damage. This we have to mention because any surgery, if it is not done properly, we may end up injuring any of the areas nearby. And in this case, the nearby structures, the thyroid cartilage, the cricoid cartilage, injured cricoid may result in pericondylitis and tracheal stenosis. This already I mentioned. And one nerve which you take care is the recurrent laryngeal nerve. Sorry. Then injure the posterior. When you are inserting the tube, if you are too harsh on it, you may injure the posterior of trachea and cause tracheostomy fistula also. So we have to take in mind that you have to be meticulous, fast, precise, and without any hurdles. You should be able to do that. The intermediate complications are either a displacement of tube. Again, this also we dealt with, but this is just emulating the various complications as such. It can be obstructed by secretion crust, then tracheal necrosis, tracheoarterial fistula, tracheoesophageal fistula, pericondylitis, and dysphagia. Again, these are the repetition of slides in the sense that already I told about what to do if it is dislodged or if there is pneumothorax hemorrhage. Then surgical subcutaneous emphysema, whenever the sutures are too tight, then you may end up with this thing. It's usually self-limiting in the first day. If it's a small amount, then don't bother about it. But if it is major, then patient may go in for either infection or other problems. And in that case, we have to start on antibiotic and see that it is proper care is taken. Scrap and crust best is that we don't allow it to form by proper care, post-operative care. Tracheal necrosis, this at least I have not come across throughout my life, but this is a possibility, a distant possibility, but still a possibility. And if proper care is given, this should not arise. Tracheoarterial fistula. Now, this is something which has been documented. It's a rare thing, but it is seen, all said and done. But the profile is the value position of the brachiocephalic artery, which is commonly one by, and best is your digital pressure and stop that area from bleeding. And we may have to have the help of CVT surgeon or other people to look into the abnormal position of the brachiocephalic artery or any other thing which we have to be sutured. Tracheal fistula, usually if you maintain put a Riles tube and maintain the hygiene, then it usually closes by itself. Many times, uh, a few times we may have to go in for surgical closure by open approach. Infection, we know how we have to take a culture and see that proper antibiotics are started, and wound dressing is the only key to it. Dysphagia, initially it is there, very much there, because the cuff which is there which is going to press on the esophagus, and patient initial few days is going to complain of dysphagia. Later on, it should not be a problem, but at the same time we should not see that the cuff is released every hourly, so that there is no ulceration developing there because of necrosis, and tracheal wall is kept intact and no fistula develops. Long term are again the stenosis, decanulation problems, and tracheocutaneous fistula and disfiguring scar. Stenosis is beyond this. Now we'll come to the other parts of tracheostomy, that is mini tracheostomy. The whole set of instruments are different here. The patient's extends, position, everything is normal. Here the thyroid cartilage is gripped between the thumb and middle finger of the normal hand, and the index finger is used. I'm sorry. Hello. Hello. Am I visible? Hello.
Can you type your question and doubts in the chat box? Sir,
Yes.
is there any? Have you completed your PPT?
Yeah. Only one slide was remaining, one or two maximum, but somehow it's not coming on the screen.
Sir, are you not able to open your PPT?
PPT is opened on my top, but I'm not getting the share button. That's all.
Sir, PPT is visible.
It's in.
Yes, sir, it's visible.
Yeah. So as just a few words regarding the. Oh, it's gone again. Somehow it's getting closed off in the PPT. That last slide is a problem. Is it seen again? Hello?
Yes, sir. 89.
Yeah. That is what we are almost reached the end of the presentation. Again, it's getting closed. When I make it to full screen, it's getting closed. So I'll just not keep the full screen.
Okay, sir.
Somehow your full screen is not working there. So it doesn't matter. I'll just go to that slide. Yeah. Yes. Okay. So this is the regarding the mini trication or the
Yes, sir. It's fine.
so this is usually the instrument which is used for mini trichostomy, and it's a minimal radiology which has been described in 1950s and 1960s. It's a patient is usually placed in normal position which I already described, and the needle and the cannula should be properly checked with the syringe which is shown in the picture there. And I'm sorry, I'm not able to go into that full screen mode. This is
Sir,
yes.
I'm not able to do it.
The thing is, it's causing here. This is the mini trichostomy wherein it has been or the percutaneous trichostomy. I can see the markings are there. This is the thyroid cartilage, the cricoid cartilage, and below that, and these are the various instruments which is used for percutaneous trichostomy. And with cell technique, we have to put inside with a needle and then go on putting the cannula and slowly and gradually dilate it and put the tube in a proper position. And this is what is a percutaneous trichostomy. And last is the decannulation. As I told you, there are various methods of decannulation. This yeah, that's it. This is bibliography. So tell you in a few words, this tube size when you are trying to decannulation or remove the tracheostomy tube as such, we have to go on reducing the size of it or close it off and observe for 24 hours. And if everything is fine for 24 hours, then close it off for 24 more hours. That is for 48 hours. And beyond that, there is no problem. Then you can lightly switch it off and close the tracheostomy tube. That is how the decannulation is done. So this is the great hormonal protocol for what decannulation admission, downsize it. That is gone reducing the size of tracheostomy tube, block for 12 hours, then overnight again for 12 hours. Some people say 24 and 24 hours, but all said and done, once we have to basically be sure that patient is able to tolerate the block properly. And once the patient is tolerated properly, then the stoma can be either closed by adhesive taping or dressing, or many times you may have to suture it off. After suturing, we just see that one day the patient is observed in the ward and then discharge the patient. That's all. And this is a various textbook which have been referred for your this particular presentation. It includes all the editions of Scott Brown, last 3 editions, and Eugene Mayer's, Cummings, and Stelmaran's textbook. And that's all. Thank you all for this. Any questions are there, please put it on there. Hello?
Yes, sir.
Yeah, the last slide, that is. The end of presentation. So any questions are there, then they're welcome.
Sir, close your presentation and then open your chat box. Then it will be more comfortable for you.
Yeah, I'll do that.
Now, sir, you open your chat box. There are no more queries.
Speed is okay, yes. So then slides not seen. That is the time I problem was there. I think that is clear. Any more questions? Anybody from anyone? Okay, the speed was okay. Only that one that around 6:43 the slide was not seen. And I think that was taken care of. I showed that again. There is one question from Yuvraj. Greater Roman Street protocol used for predator or adult tracheostomy. They can be used for both. There's no, anything against that, but because post-operative care or any care for that matter is the same, whether it's pediatric or adult. We have to basically see that the patient is tolerating the block very well, and once it is you're confirmed about it, then you can close it off. What I mean is the tracheostomy tube can be opening can be closed off. Initially, if it is fresh, say a few weeks back it has been done, then you can just put a crepe bandage around it and just see that the wound is approximated and then it heal by itself. Because once the natural airway is started, then the abnormal airway which you have created, that is a tracheostomy opening that you have done, will naturally close up by itself. If not, then we may have to suture in the rare cases by 1 or 2 stay sutures by silk, and like any other wound, after 1 week you can remove the sutures and it will be healed properly. And as long as you are not injured the cricoid cartilage, there is no chance of stenosis also. Any other questions? See, there's a question that when was the indication for decantation? Decantation, whenever we think about discharging the patient and the patient has got normal airway, his initial period of the need for tracheostomy is overcome, say for that matter, because of the water obstruction is there, or infection is there, or if he has improved from the stroke, that time the patient is going to be said to be home and he's able to breathe normally through his airway tract. Then we have to decondense, that is remove the tracheostomy tube. Decondenation is nothing but removing of the tracheostomy tube and discharging the patient. So I think that answers. So that Dr. Anwar, that is the indication, means there is the decontamination procedure which you have to do before discharging the patient, because either the patient goes with the training for tracheostomy care or else he doesn't need tracheostomy. In that case, you have to remove the tracheostomy tube, and that remove tracheostomy tube is decontamination, and that has to be done when you are discharging the patient. Next is, what is if we use smaller size tubes for adults? Now see, smaller tube also the oxygen will be there, but patient will not be very comfortable. Normal size means the size which the patient has got trachea, that much size if you use, or slightly lower than that, that will make the patient more comfortable and maintain the SpO2 also proper. Otherwise, it's like patient need more oxygen and you are giving less of it. So that is from a number. There is a private 2519969396. Okay, there is a question that what if you use smaller size tube? As far as saving the life of patient is concerned, the small tube also is quite okay, because oxygen is needed, and whenever it is needed, if you give it, it is nothing wrong in it. But to make it comfortable for you also and for the patient also, we use a proper size tube. There's a Amrita Radhakrishnan who has said that if it is possible to put a live short video, yeah, that can be put. It's not a very rare procedure. It's commonly done in all ICUs. Practically every alternate day I get a call for that. So that I'll make a video and put it up. No problem at all. Yeah, that's not a problem at all. This record I don't have it at present, but I can put it up. Given the occasion, I'll give the video to you, and it's a simple procedure. Just because it is life saving, you should not be scared of it. But and because we are dealing with all the important structures, but if you stick to the midline and do the steps properly, there is nothing serious about this. It hardly a 10-minute job. Provided all the instruments are there with you, of course, because if you are talking about district hospital, many times the instruments are not there. But in that case, obviously, nowadays things are available and should be available because it's life-saving procedure, and these are should be there should in any emergency OPD departments. Practically every emergency room should have at least 2 tracheostomy tubes sets, and every ward should have one set, and ICU should have always one ready, sterile, to be opened whenever the patient needs it. Of course, nowadays it is not as bad as it used to be, say, 2 or 3 decades back, because the quality of intubation tubes improved so much that we can keep it for a long time. And intubation, if it is possible, then it's the best possible thing. Almost 2 to 3 weeks can put the newer intubation tubes. Previously, the intubation tubes you put more than 48 hours or 8 days, they used to cause their own irritation and problems. The stenosis also used to be there, granulocytes used to be there. Nowadays, the tube quality and the material is improved, and they are more, patient friendly and human body friendly. So intubation is preferred methodology until unless, of course, there is a clear-cut indication for tracheostomy. That is what I was talking about in initial slides when I was talking about the period of rationalization. Now it rationalize which is more easy, better for the patient, either intubation or tracheostomy. Because given a situation, intubation is a very fast job and can be better done. The only problem is that patient will not be able to, has to be under sedation when you do intubation, because you don't, you can roam around with a tube inside your mouth going to your lungs, right?